So we are talking about the topic which is a game changer in the era of treating diabetes, and year on year over the decades we have been inventing, discovering new molecules in the treatment of diabetes and allied diseases like cardiovascular, renal, and other diseases. But still, it's a long way to go. You can see in this slide way back almost a decade back in 1920 when insulin was invented and started. After that, sulfonylureas, the favorite diabetes treatment in India. It was way back in 60 years back. Then from this decade, you can see all these new molecules have started coming. The first was alpha glucosidase inhibitor, then TZDs, and GLP-1, DPP-4, which was a game changer before, then SGLT2, almost 5-6 years back. But then still, people with type 2 diabetes and the glycemic control, you can see this pie chart. There are many patients who the A1C is still not under control. It's only almost 20 to 25% people whose A1C is under control. So, and despite availability of these numerous treatments, what I just said, it still remains the ninth major cause of death, not in India but globally. 50% of the patients with type 2 diabetes presents with microvascular complications like kidney disease, retinopathy, neuropathy, and almost 25 to 30% patients present with macrovascular complications like cardiac disease, CVA, stroke, and 25% of the patients with diabetes have diabetic kidney disease. Lots of patients now are pouring in our hospital with diabetic kidney disease, and unfortunately we have to put them on dialysis after some time. So the quest for an ideal anti-diabetic drug, as you can see, this number 6, 7, 8, 9, 10, the magic figure of 7, everybody is in is in mind. We have to achieve the target A1C 7 or less than 7. But while treating the diabetes, you have to take care of hypoglycemia, especially in senior and super senior citizens. Always our desire is to the lower the blood glucose, but at the same time we have to check that the weight is also not gaining much, and also the off target effects. So there should be minimal off target effects. There should not be any weight gain or weight loss. There should be a good glycemic control and very very low risk of hypoglycemia. Very important slide of this talk. You can see. I'll discuss the first one, that is sulfonylureas, and I'll directly come over here. The sulfonylureas, why? Because it's major in the majority of the treatment of our prescription. I'm sure Dr. Vineet Jagnany must also be prescribing. In that, its majority of the prescription is sulfonylureas. Efficacy, yes, it's high. Hypoglycemia risk is moderate. Weight effect is yes, it is more, but CV benefit is neutral. Now I'm coming to DPP-4 inhibitors and SGLT2 inhibitors before the GLP-1 receptor agonist. DPP-4 inhibitors, yes, there is increased insulin secretion, decreased glucagon secretion. The efficacy is intermediate. The hypoglycemia risk is low, and there is weight effect. Yes, it causes weight loss sometimes, and CV benefit. Yes, it is having a plus plus. Same SGLT2 inhibitors, there is decreased glucose reabsorption, intermediate efficacy of A1C with low hypoglycemia risk, with weight loss, and also having a CV benefit. So DPP-4 inhibitors compared to SGLT2 definitely scores over there. But now coming to GLP-1 receptor agonist, there is an increased insulin secretion, decreased glucagon secretion, and it shows gastric emptying, increased satiety. So this helps in reducing weight. Efficacy is high, hypoglycemia risk is low, weight effect, yes, it reduces, and CV benefit, definitely it has CV benefit also. So compared to DPP-4 and SGLT2, this is definitely having an edge. The best in the sugar control is insulin, although in Indian patient it's a villain. Whenever you start prescribing insulin, people, the patients are unhappy with you, but it remains with the highest efficacy. With the newer insulin, now we have low hypoglycemia risk, but with the older insulin, yes, it was a challenge while treating patients. Weight effect, there is a weight gain, that is a sorry state of that, and CV benefit, it is neutral. There is no plus plus in that. The myriads of effects of GLP-1, what the topic of today is in the human body, you see, it acts at all the levels. In the liver, it decreases the hepatic glucose production, increases the hepatic insulin sensitivity. In heart and vessels, there is a cardio protection and increased vascular protection also at the same time. While brain, there is decreased body weight, decreased food intake as there is increased satiety. Pancreas, decreased glucagon secretion, increased beta cell function, increased insulin biosynthesis. The GI tract, it decreases the gastric emptying. Kidneys, there is good nephroprotection, and in muscles, there is good insulin sensitivity. So it plays a very important role at all the levels. Now the GLP-1 receptor agonists vary in the molecular structure and size. The exenidine-based therapies, we used to give weekly exenatide extended release or once or twice weekly, that is lixinatide. Now, difference in the source of origin, molecular weight has shown to affect clinical efficacy across the GLP-1 landscape. The liraglutide, the dulaglutide, the lira is once daily subcute, whereas dula is once a week subcute. All this, unfortunately, it was through the pen, it was through the injection, and it has to be given in a insulin-like therapy. People not use to differentiate between insulin and GLP-1. Now, pathway 2, oral anti-diabetics, the A1C less than 7, as we said, the real-world clinical outcomes intensification with GLP-1 receptor agonists, OADs, or insulin in type 2 or two or more oral agents. So the A1C target, as I said, significantly more patients reach A1C target with adding GLP-1. In the weight outcome, significantly more patients had no weight gain or more than 3% weight loss with GLP-1. Significantly more patients were able to discontinue more than one oral anti-diabetics with GLP-1. And the p-value you can see is very significant, less than uh, 0.001. And the composite outcome, significantly more patients achieved composite targets along with discontinuation of at least one baseline OAD with GLP-1. So that was definitely a winning situation when you add the GLP-1 in your treatment dictionary. So multifactorial mechanisms and final effects of GLP-1, you can see. One second. Yeah. So, it acts at all the levels: insulin secretion, glucagon suppression, natriuresis, appetite suppression, and cell survival also. So, one second. I will just reduce it to yeah. The quest for an ideal anti-diabetic drug still continues for cardiometabolic benefits, where you have now the GLP-1 receptor agonist, decrease A1C, decrease fasting and postprandial, minimal hypoglycemia. There is weight loss you can use in obese diabetics. CV benefits are there, so you can use for cardiac patients. Tolerable side effects profile. If patient counsel the patient well, definitely you can. The patients will continue with this medicines and approve with wide variety of patients. So again, as I said, in quest for an ideal anti-diabetic drugs, we still, the challenge is still on. But when we are using GLP-1, what was the challenge? The large molecules, so it was in an injectable presentation. People with type 2 diabetes have a preference towards a daily oral rather than even still a weekly injection. Of course, the cost is still a point, but still, अगर आप उनको injection देते हैं once a week, still they have it in a mind that they have to take an injection, although it is once a week. So the fear of injection, the phobia may still remain a barrier to the use of GLP-1 receptor agonists in both the patients and the physicians while prescribing. There's always a fear that the patient will leave the physician and go to the other physician. So in India, definitely the oral pill is the first choice, the choice of treatment for the patients and the physicians also. So when you understand the patient preference, you have to definitely when you see this slide, previously or still now, there are many patients who still use the vial and syringe because of cost. Then there was a tailored engineered pen injections where you can put it in your pocket or in your purse while carrying while traveling. But now we have the oral tablet form still is the biggest choice of Indian patients. The rationale for oral delivery of peptides, there's an unmet need for safe, non-invasive, and convenient mode of therapy. It improves the patient compliance with a very big C compliance and expand the treatment options. So when you're prescribing a medicine to the patient, the compliance is very good. You feel good. You prescribe, the patient takes. When you come for the follow-up, you have a very good positive effect with good A1C control and weight loss. Early commencement of treatment and better patient outcomes. Because many a times, if you prescribe an insulin or a GLP-1 in an injectable form, they will start after a month with this, with discussing all their relatives and all ki bhai karna zaruri hai. Is it really necessary and worth it? So it addresses the barriers associated with the subcute administration. So the quest for the first ever oral GLP-1 receptor agonist, it's an oral base, it has an enzymatic degradation, limited permeability and low oral bioavailability. So the working hypothesis, it is almost 5 lakh fold decrease in bioavailability, 1000 fold increase in by safe enhancer, 10 to 100 fold increase in GI enzyme stability, and 5-fold increase in potency. So to put all these in one dosage form, definitely it was a challenge. So the foundation stone of the peptide in a pill, the protein in a pill, the semaglutide was launched, and SEMA was a discovery which led to the path-breaking innovation in bringing the GLP-1 in a pill, what we call the PIP, the protein in a pill, and the co-formulation with an absorption enhancer. It allows oral semaglutide to be absorbed from the stomach and promotes absorption across the gastric epithelium, and also protects the oral sema from breakdown by the gastric enzymes. So yes, as you have seen, it's in coming in an oral formulation. The oral SEMA, the first in class, the oral GLP-1 receptor agonist. It's a new oral route of administration for the protein in a pill. Was possible with an absorption enhancer. So the viability is low, variability in absorption is very high. Mitigated by 1 week or week half-life and once daily dosing. Several treatment doses, but patient compliance with the dosing condition is very high. The tablet co-formulation with the snack is an enhancer, as I said, that facilitates the absorption. That the available data for semaglutide co-formulated with snack support that absorption takes place in the stomach in a localized buffered environment. The effect is strictly time dependent and occurs primarily via the transcellular route. As I said, the plasma semaglutide concentration was measured by the LC and MSMS. Concentration time profile confirmed early systematic absorption and apparent slow elimination. So that's why the level is high once present in a systemic circulation. Plasma concentration of SEMA after 10 mg oral dose, you can see it lasts for almost 24 hours. The mechanism of absorption, as we discussed before, the absorption is in stomach. It requires co-formulation with the snack. Snack causes a local increase of pH, leading to higher solubility and protection from proteolytic degradation. That's the importance and beauty of snack. And the effect of snack is strictly time and concentration dependent and fully reversible. Approximately 1% of SEMA is absorbed. The rest is degraded in the GI tract. The oral semaglutide was well tolerated in subjects with varying degrees of renal impairment. So, renal impairment did not appear to impact the pharmacokinetic properties of oral sema following 10 consecutive once daily doses. And no dose adjustment of oral semaglutide is hence necessary in subjects with renal impairment. And also for the hepatic impairment, it was well tolerated in patients with varying degrees of hepatic impairment, and there was no dose adjustment required. So it is convenient for you and your patients. No dose adjustment recommended regardless of the renal or hepatic impairment. No dose adjustment recommended in elderly patients. And there is very, very low risk of hypoglycemia across the Pioneer trial. It's a very important trial with this molecule. The Pioneer program dosing rationale and instructions. It was based on phase 2 trial results that 3 once daily dose levels was expected to have optimal benefit risk profiles, and that was 3, 7, and 14, which is available now. And oral SEMA was initiated with the lowest dose and a 4 week dose escalation. Every 4 weeks, you escalate the dose to reduce the risk of GI adverse effects like nausea and vomiting. So what we usually prescribe and counsel the patients is to take the medicine on an empty stomach. Take it with a sip of water, not more than around 120 ml. Wait for at least 30 minutes before eating, drinking, and taking any other oral medication. So what usually we prescribe and counsel and advocate is early morning when you get up, take it on an empty stomach, this pill, semaglutide, with around 100 to 120 ml of water. Go for a regular walk or go for your brushing, teething, and answering the nature call. And then after 30 to 40 minutes, you can go ahead with taking the other oral medications. Like many a times, patients confused with the thyroid pill, which they take the early morning. So after 30 to 40 minutes, they can take on with continue with their breakfast or the morning supper. So oral semaglutide dosing instructions is designed to optimize absorption and be convenient for the patient. Factors decreasing the SEMA exposure, food intake prior dosing. Yes, we have to be very careful about that. Increase water volume. As I said, it was 100 to 120 ml. You should advise the patient and decrease post dosing fasting time. At least, as I said, 30 to 40 minutes you should wait after you have something. As I said, practical approach of managing the nausea with GLP-1. 80%, almost 80 to 90% subject tolerated this treatment with oral SEMA and did not experience any nausea to begin with. It was only 10 to 20% patients who were having, like, there are like hyper patients and those who are having, before the medicines also they have problems with other molecules also. The discontinuation of oral SEMA was uncommon and mostly occurred only in the initial dose escalation, that is from either 3 to 7 or 7 to 14. And if needed, so we have patient focused management strategies could be help to persist with the oral SEMA. We can advise the patient to pause for some time, then encourage to resume after the nausea vomiting is decreased. And with a probably a 2 or 3 weeks pause, we can re-escalate from the lower dose. So as I said, you have to make the patient aware of possible GI effect, the side effects. You have to suggest mitigating the measures such as diet modification, and patients should seek medical advice for severe or persistent symptoms if at all they have. Diet modification plays a very important role, and you have to counsel the patients when you prescribe any OADs, and especially this one. So again, to summarize, peptides are challenging compounds and require engineering to optimize their in vivo performance. Peptide analogs can be designed to offer improved stability and prolong the T half, while a formulation approach can facilitate improved absorption. Absorption of oral semaglutide takes place in the stomach and it requires co-formulation with a snack. Mechanism of absorption is shown to be compound specific, transcellular, and without any evidence of effect on tight junctions. Development on the PIP, the magic peptide in a pill, the oral semaglutide, represent an advancement in treatment possibilities of for chronic diseases by transforming injectable therapies in tablet-based oral formulation. I thank the team IACC, Dr. Vinit Jagnany, team ClearNet, Dr. Sheetal. For any questions, we are open for that.